the topic per se. I thought we will just brush up our anatomy and physiology of the salivary glands. The major salivary glands are the pad organs in the parotid, submandibular, and sublingual glands. We have the minor salivary glands in almost 600 to 1000 of them are there. They are small glands in the upper aerodigestive tract. Why this is important is minor salivary gland tumors can occur anywhere in the upper digestive tract. That includes the soft palate, the hard palate, the pharynx, pharyngeal mucosa, laryngeal mucosa, esophageal mucosa, and even tracheal mucosa. So remember that minor salivary gland tumors, like for example, an adenoid carcinoma, can occur even in the trachea. So salivary gland tumors can occur anywhere in the upper aerodigestive tract because these minor salivary glands are located there. Now, uh, this is located basically in the mucosa of the upper aerodigestive tract. Minor salivary glands can be located in the mucosa of the upper aerodigestive tract. The sites includes, as I already told you, oral cavity, pharynx, larynx, and also the paranasal sinuses. And the greatest density of minor salivary glands is located in the palate. Now, going back to embryology, how does these salivary gland tumors come? And when salivary glands develop, the proliferation and growth of cells from the oral epithelium into the underlying mesenchymal tissues is responsible for the start of development of the salivary glands. It starts about the fourth to fifth week of the life. The parotid glands are the ones to develop first, gets encapsulated last, allowing lymph nodes to be entrapped within its substance. So this is important. Why this intraparotid lymph nodes develop is because the parotid gland itself gets encapsulated last, and therefore the parotid gland can uh, entrap some lymph nodes along with its substance. That is why you have intraparotid lymph nodes. Now, parotid is the largest gland, measuring about 25 grams in weight. It is pyramidal in shape, and the situation is the retromandibular fossa. Why I am saying this is repeatedly is where is the parotid fossa, or what is it also referred to as, is an important question that clinicians ask. Retromandibular fossa. So it projects over the sternomastoid, the masseter and digastric muscles, and an important structure called the deep cervical fascia encompasses it. The parotid fascia is nothing but a condensed form of thick deep cervical fascia. What is the importance of the deep cervical fascia? That is the overlying the parotid. That is the parotid fascia is because it's a very uh, dense, thick structure. Parotid tumors, the cystic tumors of the parotid or and parotid abscesses, you will not be able to elicit fluctuation because of this thick substance in the form of a parotid fascia. And that's the reason why you don't wait for fluctuation to happen in a suspected parotid abscess. So this is the importance. And this retromandibular fossa, you should keep in mind that it has some limitations in the sense that it is bound, the parotid fascia that goes and gets bound at the level of the zygomatic arch and posteriorly up to the mastoid process. And that is the reason why a parotid gland, even when it enlarges, it stretches beyond this area but does not go beyond them. That is, it will go up to the zygomatic arch and up to the mastoid. Beyond that, it doesn't extend because the parotid fascia is densely adherent. So this is the importance of the parotid anatomy that we are talking about. Parotid duct is about 5 centimeters in length. It courses lateral to the masseter, and at the anterior border of the masseter muscle, it pierces the buccinator. The duct enters the oral cavity and opens opposite the crown of the upper second molar tooth. Why is this important? This parotid duct is an important structure that you have to keep in mind whenever you deal with some oral malignancies. For example, if you have an upper the upper gingival growth or upper alveolar growth close to the second molar tooth area, when you plan resecting over that, you have to keep in mind that you will be resecting the parotid duct orifices there. So if you do not plan that and put in a flap, the salivary gland secretions are going to get blocked because of the flap, and you will have a post-operative parotid collection. In fact, sometimes tumors per se can block the parotid ducts and produce a parotid gland which is enlarged. That is, parotitis can happen and they can even present with a parotid abscess. So this is something that you have to keep in mind whenever the parotid duct anatomy is to be kept in mind. Another important thing that you should be aware of is the Patty's fascio-venous plane. Now, this Patty's fascio-venous plane has three important structures: a nerve, a vein, and an artery. The main important nerve is the facial nerve and its branches. We will deal with the branches of the facial nerve and its importance. Very, very important structure. And then is the retromandibular vein and the external carotid artery which goes in them. So generally, the plane is in such a way that it separates the superficial from the deep portion of the parotid gland. So the Patty's fasciovenous plane separates the superficial portion of the gland from the deep portion of the gland. And that is the reason why when you encounter a lot of bleeding when you're doing a superficial parotidectomy, it means that you may be going in a very deep plane. Going a little above that plane will be the proper avascular plane where you should be able to dissect out and spare the nerve and its branches. Now, this is about the histology of the salivary gland. So, basically, you have the individual lobes that have these capsule and small septations between the lobes, and secretory units drain into what we call as intercalated ducts. They in turn drain to the striated ducts. All these striated ducts together join together into the collecting ducts and opens it into the gland to go and drain into the parotid duct. So this is how the glands are arranged. Now this is the microscopic picture. The, the myoepithelial cells line these acini. That is the mucinous acini cells. They secrete the mucus from the gland. And then you have a serous demilunar cells where you have the serous cells. They'll go into the intercalated ducts. Then you have the striated ducts, the collecting ducts, and ultimately from the intralobular, you have the interlobular, and finally they go into the